All right, hello. My name is Brian Everett. I'm one of the medical directors with Converse Fire Department, Windcrest Fire Department, Bear County Emergency Service District 10 and 12, and I'm one of the EMS physicians in the Office of the Medical Director, UT San Antonio. So today we're going to talk about patient handoff and why this is such an important part in the patient care treatment process. This is actually one of the most dangerous times in the patient care area. So we must take this very seriously because the patient is going to be turned over a handoff several times during their care process. And one of the first times this happens is between the first responder and the transporter. So this may be interagency or different agencies, but we need to stop, pause, and take a moment to fully explain what is going on with the patient and have a discussion about what the treatment plan is with the patient. So, like I said, this is dangerous, and there are several things that could happen during this handoff. And like I said, this patient will be handed off several times during their treatment process, and that may lead to loss of important information, delays in diagnosis or treatments, or duplication or failures to provide care or treatment that they need. So this may be like they need a test and it's not done. There may be a missed injury because one person thought it was done and it wasn't. There may be important information such as the patient has had stenting in the past and now is having chest pain that may be lost during this process. It's estimated that about 80% of serious medical errors are related to the handoff, that something was missed during the patient handoff period that led to the patient having either an injury or some other kind of medical error. There are several handoff options. They all have acronyms that stand for different things. So you may hear SBAR, you may hear IPASS, and one we use here in the STRAC region is called MIST. And this is for our transporting agencies, something they're used to doing. They get handed this sheet every time they walk in through the door, and that allows them to make sure they're giving the right information every time. And we'll kind of go through this process because we're going to start employing this out in the field. Now, we're not going to necessarily fill out this form. There may be something that we want to do to try and make sure that we keep the information together, but for the most part, we're not going to be filling out forms and that sort of stuff. But we do want you to give handover in a clear, delineated manner that hits each parts of these areas. So MIST, the M stands for mechanism or the medical complaint. I stands for the injuries or what you find during your treatment. This is kind of your OPQRST when they started, what it feels like, and that sort of thing. Signs has to do with vital signs, and treatment has to do with what kind of treatment you're doing or what you think is going on with the patient. Now, this is probably the most important part, is that we should always start with an introduction. We should have the arriving person that's going to take care of this patient introduce themselves to the first responders that are on scene. And they should do this in a manner that one talks about who they are, what kind of rank they have, what kind of medical clearance they have. So are they a paramedic? Are they basic? And what agency they're with. And that allows the first responder to at least understand who they're talking to and what kind of level they are and what's their role going to be in this. So, for example, if myself as the EMS physician arrives on scene, I might introduce myself as Dr. Everett. I'm one of the EMS physicians in the area. Just kind of want to know what's going on with the patient. And I might stop and I want you to introduce yourself. You may say that you're the, Joe Smith and you're the basic with one of the ESDs. And that kind of lets me know what kind of information you can do and what you should have gathered in that time period. It's also slows everything down. It allows us to kind of slow down the process of doing this turnover in a area that is both structured and important information. And this includes this to be done in critical situations. It shouldn't take long, no more than 30 seconds, but it slows down the pace of things, allows everybody to take a breath and know what's going on with the patient. So M has to do with the mechanism or medical complaint. So you may say that this is a patient that's been involved in a head-on collision, or this patient is complaining of chest pain. Next, we want to talk about what injuries we found on inspection, where we've inspected or what we haven't inspected. It's important to include our pertinent negatives in this part. As far as inspection goes, this is kind of our OPQRST or old cards, depending on which one you want to use, or DCAP BTLS. It's basically talking about when this started, what kinds of how they describe their complaint, how it compares to previous. Does it go anywhere? Does it stay there? Have they ever had any kind of medical history that's pertinent to that area, that information? Are they taking any medications? Do they have any surgeries that are pertinent? All this information is kind of in this section. Next, we're going to talk about vital signs. And remember, vital signs also include end-tidal CO2 on most of our patients, and a blood glucose if they have some reason to be altered or have a reason that may recommend that their blood sugar is either high or low. If you haven't been able to get one part of the vital signs, it's important to communicate that. For example, that you're at a chest pain and you haven't been able to get a 12 lead before the transporting agency arrives. You may say, hey, I've got started the vital signs, I just haven't got a 12 lead. And that's important because it tells us that, hey, that's probably the next step we need to take. And then finally, what kind of treatments we've done. Have we started IV? Have we given fluids? For our chest pain patient, have we given aspirin? Those are important things. So we don't have to duplicate those efforts in the long run. And this kind of takes us into, this is kind of a consultation. This is a discussion among colleagues about the patient's care. It may be at this point that you say, I think this is going on with the patient, and I think the next step should be X. And that allows the provider that's already on scene to communicate their thought process, and then the provider receiving the patient to understand what their thought process is. It's important to ask the question, why? Why do you think this is going on? Blah, blah, blah. If you have a disagreement in the process based on the information you've given, it's important to say, I may disagree, and this is why. And then you have a discussion kind of addressing those issues. That's how we do it in the hospital, is if we are thinking one thing and our consultant thinks another, we may have a discussion about why that is. These are very collegiate discussions. There should be no getting upset or anything like that. The idea is that we all have different approaches to medicine. We all have different experiences that shape the way we perform medicine. And it's important to have a discussion on why we either disagree or agree with a treatment plan. And it's important to understand the idea behind CRE resource management. And that is that everybody involved in the patient's care is an important component of the patient's care. And they should have the right to speak up and give their opinions about what is going on with the patient. So, for example, you may be a basic and you may note something on the patient's care that may not have been fully displayed between the two paramedics. It's important that you speak up during this process and say something so that it's made sure that the information is fully delivered. For example, they may say, we put in a size 6.0 ET tube, but you actually notice that the patient has a 7.5 ET tube and it's at 24 at the lip. You may say, hey, just so you guys know, you said 6.0 ET, but it's actually at 6.5 and we're at 24 at the lips. So that may actually cue on to the other person. Maybe this is a little deep. I don't know, but we'll see. So this is important information to pass on, and is an important part of that. Everyone involved in the patient's care understands that they can speak up during the turnover if important information is not being uh, properly turned over. So, in conclusion, remember to the most important part of this whole thing is to introduce yourself, to slow down and think of the turnover as a consultation, as a time for you to have a collegiate discussion on the patient's care. Make sure you understand all the important information that's being passed on, and understand what the thought processes of the first responders and transporters are, so that this patient gets the most specific and highest level care they could possibly get, and it is safe. So if you guys have any questions, again, my name is Brian Everett. I encourage you to email me or call me at any time if you have any questions, concerns, or thoughts about the turnover process. I look forward to seeing you all out in the street and interacting with you and seeing this in play. So be sure to practice this. I'm sure all the FTOs are going to be out there making sure that you guys are fully aware and have opportunities to simulate this. It will take time. It will take time for everybody to fully appreciate the process. And I encourage you, if you're accepting care, that you kind of make sure that it's happening. Make sure that you're getting this important information from the patients. And if you're transferring care, make sure you have that information and take your time and pass that on. Uh, so, guys, enjoy yourself, have fun, and keep up the great work out in the street. Thank you guys for your time.